And I'm looking forward to that part of the discussion as well. So today's topic is going to be, will the smoldering myeloma diagnosis phase out? Now, there's been some buzz in the myeloma community and even disagreements between different myeloma specialists concerning the smoldering myeloma diagnosis. And we've seen the smoldering diagnosis evolve over the last even decade of determining what really is high-risk smoldering myeloma and when is it treatable. And sometimes the question that arises is, could it be possible that the smoldering diagnosis phases out just to leave MGUS and active myeloma? So Dr. Kourelis is here today to provide his opinion on the subject and help us understand how we can use this information to better manage our care. It's now my pleasure to introduce him to you, and he's going to introduce himself a little bit more as well. Dr. Kourelis is a hematologist, internist, and oncologist working in the bone marrow transplant program in the hematology department at the Mayo Clinic in Minnesota. In 2015, he got his hematology oncology degree at the Mayo Clinic division. He got his oncology degree, and later in 2016, he got his myeloma, amyloid, and dysproteinemia disorders advanced fellowship. So I'm going to turn the time over to you now, Dr. Tax, to be able to explain more about yourself and then launch us with this subject of is smoldering gonna phase out or not? So I'm looking forward to it.
Yes, thank you, Audrey, for the introduction, and everybody for gifting us your time and attention today. I hope we'll make the best of this. Let me share my screen. And again, this is, I think, meant to be an informal, interactive, presentation. So feel free to ask questions whenever you feel like something is confusing, okay? So I'll just give you a practical perspective. I was discussing with Audrey, it's always nice to have, two opinions. Like, eventually I have to give you my opinion. I'll try to balance things as much as I can and give you both perspectives. But again, if anything is not clear, these are my disclosure, just some research dollars from Novartis looking at IL-1 inhibition in smoldering myeloma. So the outline of this presentation, we'll keep it practical and straightforward. Just a slide on who am I. Some definitions. I think these are important. I mean, I understand many of you are dealing with these conditions. I don't want to call them diseases, but conditions, or have family members that deal with MGUS or smoldering, and then start with why some folks say that myeloma, smoldering myeloma won't exist, why some others say that it will. And I think it's important to discuss this in the context of how has prognostication of these precursors evolved, right? When the myeloma diagnostic criteria would change in 2014, it's because they were more refined, and when we identified an extremely high risk subset of patients, high enough to say, these smolderers just get treated because they're going to progress into myeloma very, very quickly. So I think this is where this whole discussion is arising from. So we'll discuss the history of prognostication, existing trends, and also a little bit of lead time bias, and actually what does it mean when you try to shift the diagnosis of active myeloma, right, which means therapy earlier in the disease course, and then conclude and discuss any questions. So, well, I'm a myeloma and amyloid doctor at Mayo. I always say amyloid because that's my sort of side passion. I do some fun translational clinical research in both diseases. And I do see a lot of patients. I'm still a very active clinician, so I fully appreciate the the stress and anxiety that comes with the diagnosis of smoldering myeloma and even MGUS sometimes. And I can see why I have some patients with smoldering myeloma and MGUS being way more anxious than myeloma patients. And I can see why that is when you have a precursor that you don't know how it's going to do. So definitions, I'm going to use some acronyms. I'm going to try to minimize acronym usage, but just to save space on my slides, MGUS, as you know, monoclonal gammopathy of undetermined significance, SMM for smoldering myeloma, MM for active myeloma, plasma cells, sorting them down to PC. These are the cells that give us the, the malignant clone. Free light chains, I'm going to abbreviate them to FLCs, and these are the proteins, as you know, that these myeloma cells most of the times make, and BM for bone marrow. So definitions, right? Existing definitions place a big emphasis on, is there organ damage or is there no organ damage? Okay, I think that's the 30,000-foot view. You have any organ damage, that's myeloma, irrespective of how much of it you have, how many plasma cells, how high your M spike is, so on and so forth. If you don't have damage, you consider most of these to be precursor diseases with a few exceptions. And of course, there is the bulk-based concept. I mean, if you look at definitions of MWG, or you Google stuff, you'll see cutoffs of like M spike, less than 3 for MGUS. If it's more than 3, it's smoldering. There's ranges for your plasma cells. I don't have to go into details. There's like ranges for your free light chain ratio. If it's too high, nowadays we just call it myeloma sometimes straight away. And generally speaking, there is an increasing M spike, increasing plasma cells in your bone marrow if you had a bone marrow, as you go from MGUS to smoldering to myeloma. But this is not always the case. And then the next slide, there are just some clinical examples. And I think this is important. And as we discuss further down the road about early diagnosis and contemplating early therapy, just to get a sense of how this disease develops. And these are all patients that I've seen in the past, 2 to 3 months, all right? Patient number 1 had an M spike of 5, free light chains around 100 or so. They had bone lesions on their CT scan. They had some kidney damage, so their creatinine was going up, right? Clear-cut, textbook myeloma. This other patient had no bone marrow plasma cells, nothing at all. M spike, tiny M spike, 0.5. Light chains, completely normal. But then you do a CT scan or a PET scan and widespread bone lesions. You biopsy them, their plasmacytoma. So that's a myeloma. So again, the bulk, I guess, is a relative thing. And more myelomas have lots of bone marrow plasma cells and high M spikes, but that's not always the case. Third bullet point, you had a patient who had a prior MGUS, and they started off with a normal hemoglobin, and over the years, let's say a decade or so, their hemoglobin slowly dropped, and it dropped into 9. And 9 is the definition of the CRAB criteria, right? In the previous slide, I didn't emphasize. So the CRAB criteria is C for high calcium, that's kind of leaking out of your bones if you have myeloma. R is for renal failure, so that's usually an elevation in your creatinine. A is anemia, and 9 is a cutoff, and B is bone damage. You can see it on a CT scan, PET scan, MRI. So yeah, this patient did develop myeloma because they had a CRAB feature, right? So they had anemia, nothing else in their bones, nothing in their kidneys. Patient's feeling totally fine. You do a bone marrow, and they're like, 60% plasma cells. Okay, so this is myeloma. But the patient was, again, they did fulfill diagnostic criteria, but feeling perfectly fine because this happened very, very slowly. Another patient that I saw several months ago, MGUS for 30 years, like very slow progression. And then we end up getting a marrow biopsy, and now has 20% plasma cells. Yeah, okay, sure. Now they do fulfill smoldering myeloma criteria because they have more than 10%. But is this patient the same as a patient who walks through the door? They have an SPEP of 2 and they get a bone marrow the next day and it shows 20%, and you have no idea what's going to happen. Not exactly. So there's a bit more uncertainty in the second scenario versus this scenario. You say, okay, yeah, I mean, you got to keep a closer eye on this, but you also had this for 30 years. So, more likely than not, it's going to continue to be indolent. Or, final bullet point, patient has an M spike of 3, bone marrow plasma cells 20%, and just one asymptomatic bone lesion. Everything else is fine. Kidney function, anemia, calcium, none of that stuff. So, but again, this patient has myeloma because they have a high enough bone marrow plasma cell percentage and a bone lesion. So that just to give you an idea of the spectrum of how the disease develops. It doesn't develop always especially in patients that are followed, right, in a devastating way. It can present in a much more indolent way also. So a bit, again, high level sort of definitions, how does myeloma evolve? I guess we don't know exactly what the initiating event is. There are studies suggesting there might be some clonal meaning identical sort of brothers and sisters B cells, and B cells are sort of the grandfathers of plasma cells. You start as a B cell and then you end up being a plasma cell. So you might see some clonality even in these cases. And then on top of that, you add some genetic changes, epigenetic changes that they perhaps accumulate over time. And then this turns into a more sort of aggressive malignant situation. But whatever the initiating event is, all patients that have myeloma always started at an MGUS phase. Now, most patients that have MGUS, and MGUS is a very common condition, right? Again, all of these, the median age of diagnosis is late 60s to 70s for MGUS smoldering myeloma. MGUS is the more common precursor, right? We see it in about 2%. Some studies now say it might even be higher. 2% of the general population ages above 50. So that's, hundreds of thousands, if not millions of people. And natural history studies or screening studies done at Mayo, where we just took a bunch of patients and screened their serum, showed that only 20% of people that had an MGUS, when we screened them, actually knew that they had an MGUS. So 80% of people that have MGUS are just walking on the street, don't even know about it. Most of these folks will not progress, at least in one's lifetime. Some of them, do progress into smoldering myeloma. And again, some patients might have an MGUS, they know about it, and then, they progress to smoldering myeloma. Bit of a different concept as to, compared to somebody who just has no idea and then they get diagnosed with smoldering myeloma is a bit more uncertainty. Smoldering myeloma is a high risk precursor. Many of these patients, many more, I guess, compared to myeloma, to MGUS will progress into myeloma. And then of course, myeloma is, when you have end organ damage. In terms of basic biology, again, I think many unanswered questions. There's one group of thought saying that you have like a static model where people start with the same pool of genetic material in these abnormal plasma cells, even in the MGUS phase, and just they grow into myeloma just because they have, enough time passes and they divide, they keep accumulating, and then in the end, something happens and, you end up having myeloma. And there's the evolving model where you actually do have evolution of some of the genetic material in these pre-malignant cells, and they, some of them become more aggressive and they cause end organ damage. But this is still, I think an area of active research. Just one brief slide of myeloma and how this is currently treated. So unfortunately, for most people, and there's certainly, exceptions, but for most people, myeloma is still considered an incurable disease. You can certainly have very, very lengthy remissions. You can certainly have folks that get diagnosed old enough and, they get a 10, 20, 30 years of remission while still requiring therapy, and their life expectancy is not limited, but they still require therapy. But true cures where you give therapy and then you stop therapy forever, it never comes back in one person's lifetime, are not that common. Hopefully this will get better with new therapies. But I think the emphasis in this slide is once you start myeloma therapy, there's no going back. You get the clock starts. You have myeloma, it's not like you're going to give a little bit of therapy and then sit back for a very extended period of time and do nothing. So there is some induction therapy. Some people get transplants, some people don't get transplants. Most people get maintenance after their transplant, generally for a long time, not necessarily. There's some cases where we can, stop it. Now there's studies looking at what's a more informed way to say when we can stop maintenance. And then when the myeloma comes back, try various different medications. And then there is a point, there's just a mix and match approach. There's no great study to say, okay, this therapy is better than the other. But again, this is not very relevant to this conversation. I just wanted to emphasize that myeloma is generally incurable. Once you start therapy, that's, you can't go back. There's no going back into like a smoldering or an MGUS phase for the majority of people. So take-home points, myeloma can develop quickly or slowly, so it can have many phases, right? Said some patients can develop, with all the CRAB criteria, a very dramatic way. Other people can have a more indolent progression. Okay, now to the question of interest here, right? Will smoldering myeloma be phased out as a diagnosis? People that say, yeah, it will. They say yes, because we will have evolved, I guess, in the near future, such sophisticated ways to predict patients that are destined to progress into myeloma, that we might as well start treatment early so we can help people live longer or better. People that say no, they actually do agree that, you know what, yeah, I think fairly soon we will have very, very sophisticated ways to progress, who's going to progress into myeloma, who's not, and when. But unless we actually have clinical studies, randomized clinical studies that show that if you treat these high-risk folks sooner, you're going to make a solid impact in their long-term outcomes, meaning that you're going to make people live longer or better, then we really can't say that smoldering myeloma is not going to be a relevant diagnosis. And I'll explain that. I'll try to explain that a little bit better later on and during the Q&A, of course. Okay, so I think to discuss prognostication, which is, I think, what it all boils down to, we'll go back in time a little bit, okay? So I think prognostication started with, I think, MGUS, which is the way more common precursor. Many of the studies were done at Mayo. I'm going to highlight these, having said that there's great studies from, the Dana-Farber group, the Sloan Kettering group, Dr. Landgren. There's studies from the, the Spanish group that have sort of added to the body of literature in prognosticating MGUS and smoldering myeloma. I'm just going to highlight some of the classics, from Dr. Kyle. So Dr. Kyle was the first one who published back in '78. He got a bunch of patients and said at MGUS and said, the risk of progression to myeloma is about, 1 to 2% per year. And he showed that this was more common in males compared to females, and it becomes more common as we age. All right, these were seminal observations. Now we take them for granted, but this was not always the case. Now, more recent papers, again, Dr. Kyle still publishes, New England Journal of Medicine in his 90s, all right? And he still published updated data in a much larger cohort and says, yeah, the average risk of progression for MGUS is about 1% per year. But, if you look at some risk factors like an abnormal light chain ratio, if your M spike is more than 1.5, you can, stratify these patients a little bit better. But you can see MGUS, even if you have, high risk MGUS, right? You have both of these risk factors positive, it's still, about 1.5% per year. So it's not terribly high. So 10 years, 15%, 20 years, 30%. That's, of course, in the eye of the beholder. For a young person, this is very significant. If somebody has MGUS in their 80s, this might not be as, anxiety provoking. Other groups, again, Dr. Landgren has the concept here in the non-progressing versus progressing patterns is that, look, okay, we can have a static prediction model where you say, okay, patient walks through the room, we get their labs, and this is their average length of progression. But I think a smarter way to do this is to kind of follow these people a little bit and see how they progress. And you have M spikes that are not progressing, so their M spike over time stays relatively stable. And it's very self-explanatory that, these patients are going to do better, and patients that are progressing are not going to do as well. Now, this is a curve comparing MGUS progression rates versus smoldering myeloma progression rates. You can see that smoldering myeloma is a totally different beast. It's a much higher risk of precursor, much higher risk for progression to myeloma compared to MGUS. And you can see that I think most of the action for smoldering myeloma, meaning chances of progression, is the first 5 years. Another key point is that this is cumulative. So all of these, both smoldering and MGUS, once you have them, you can't say, I'm going to follow this for 5 years, 10 years, 20 years. If it doesn't progress, I'm okay. Unfortunately, the risk is always there for as long as we're alive with these disorders, which also adds to the anxiety of having them, right? Now, for smoldering, though, what I want to point out is that the majority of, so it says that 50% of people will progress in the first 5 years. And then you still progress over time, but if you see the curve kind of shoots up in the first 5 years, and then, yeah, it goes up, but it goes up at a much slower pace. And this is kind of important. What it tells us is that smoldering myeloma is probably, a mixed bag of people. Some of them are going to have more of a myeloma-like biology, and they're just going to behave, progress into myeloma fairly quickly. Others are going to have more like an MGUS-like physiology. And yeah, they will progress, but at much slower rates. And one of the key questions is, all right, how do you, predict the early progressors? But this is just to give you an idea of MGUS and smoldering, how they compare. And additional, smoldering myeloma prognostic factors have been initiated by Mayo and again other centers. I'm just mentioning Mayo because this has been adopted by the International Myeloma Working Group. It's been well validated, and what Dr. Rajkumar here used is three laboratory abnormalities: an M spike more than 2, bone marrow plasma cells more than 20, and a free light chain ratio of more than 20. So the 220/20 scores, kind of easy and catchy also to remember. And even within smoldering, right, you can have significant variability with 5 years of progression of about 20% of the people that have none of these risk factors, about 50% for people that have some of these risk factors, and people that have all of these risk factors. So the high risk smoldering myelomas is a risk of 80% of progression in the first 5 years. Again, this was a static model though, right? And the easy criticism is you can't really predict very well just from one time point. Things change. So you got to follow people a little bit better. And again, Dr. Landgren has done a study. So the Memorial Sloan Kettering group, now he's in Miami. Mayo has done studies. The Spanish group has done studies looking at this. And they defined, the problem with these studies is that they haven't identified a uniform definition of what's progressing versus not progressing or evolving smoldering. But they basically looked at the M spike, and they had some various cutoffs. Your M spike increases by this much, and your hemoglobin decreases by this much in the first 1 to 3 years or so. You call that evolving smoldering, and you can see that these patients did much worse. First 5 years risk of progression like 90%. This was the Mayo study that identified a bunch of other risk factors, and even the first 1 to 2 years, you can have like a 90% risk of progression. The problem with these studies is they haven't been validated as well. That's why these haven't made it out to they haven't been incorporated in international recommendations. But it does show you that in addition to a static prognostic model where you sort of try to predict the future by just getting one time point and seeing what's going to happen in the future, you can, following things over time, makes more sense. And this is something that all of us do routinely in the clinic. These studies have tried to quantify it a little bit better, but they haven't been validated as well. That's why they're not used very frequently. And the more recent and more cool stuff, of course, are looking at other more sophisticated pieces of information. So not just what you see in the chart, right? And easy laboratory parameters, but what is actually happening down at the genetic level. So this Dana-Farber study from the Gobrial group, right, which is, I think, performing all, if not most, if not all of the cool research in myeloma precursors currently. And they identified various gene groups, and if you had some of them, you had a high risk of progression. If you had others, you had a low risk of progression. And this just gives you a flavor. This again has not been, this was actually validated, but it hasn't, come to the clinic yet because, you need larger data groups, more samples. These are expensive tests to perform, but it just gives you an idea of where this is going. We're just not going to look at, hemoglobin and light chains and M spike and, bone marrow plasma cells that some people might say, might be quite crude, but you can look at, the genomic information. Who knows? Maybe the next step is looking at the genomic information in dynamic matter, every year or something. Again, the Spanish group has done, phenotyping, where they look at surface proteins instead of the genetic material and how these change or how these correlate with progression. Single cell approaches where you basically, instead of kind of getting all the myeloma cells together and analyzing their genetic materials, you try to identify the genetic material in each and every cell. And that's important because you might have some, for instance, patients that have, high risk smoldering myeloma, and that's because a tiny amount of their myeloma is expressing some very high risk genetic anomalies. But if you get all of their myeloma cells and you look at them a genetic standpoint, you're like, all right, this doesn't look that bad. But if you look at them at a single cell level standpoint, you can really identify the bad players that are destined to sort of expand as time goes by. So prognostication take-home points so far. So progression risk on average is cumulative. So again, it's not one of these things like I'm going to follow it for 5, 10, 20 years. I'm going to stop worrying about it, unfortunately. MGUS, even high-risk MGUS, usually does not progress and does much better than even low-risk smoldering myeloma. And again, smoldering myeloma is a high-risk precursor, and some of them can be, have like an MGUS-like physiology. Some of them can have a myeloma-like physiology. And there's, let's say, there are various risk models that have been developed. Some of them are better validated and have been included in clinical studies. Others are now being sort of explored better, and they're more refined. So here's bringing us back to our initial question, right? Why do some people say that it's just going to be phased out? The idea behind this is that our ability to prognosticate ultra high risk smoldering myeloma, right? That's people say in the near future, we're going to have the perfect calculator. You're going to plug in your laboratory values, your bone marrow parameters, your genomic stuff, your immune profile or whatever else comes out. And it's going to tell you, you're going to develop myeloma, active myeloma, right? With CRAB features and all the classic stuff in 2 years, 3 months, 1 day, 6 hours. Guaranteed, 99% accuracy. And these patients we should treat. So definitely agree with the first part. The second part is where it gets complicated. Now, bear with me because this can get confusing. All right, so what folks that are, I guess, betting that early, the smoldering myeloma is going to phase out, they're betting on this scenario here. So you got 2 patients, one of them has smoldering myeloma that's destined to become myeloma, right? This is destined to become myeloma here, but you say, nope, I'm going to start therapy here. So you start therapy here, and then unfortunately the patient, dies there. This patient says, I'm destined to become myeloma, but I'm going to delay therapy until this actually becomes active myeloma. So this is the active myeloma part, right? You start therapy there, and this patient dies sooner. So you do have some life gained by starting therapy earlier. So folks that say smoldering myeloma is going to phase out as a diagnosis are hedging their bets that are going to be able to identify progressors very accurately, early progressors very accurately, and that by starting therapy, going to make them live longer. Scenario number 2, however, could be this. You start myeloma therapy there. These are both aggressive myelomas, smoldering myelomas, right? Aggressive smoldering myelomas, they're going to progress quickly. You start therapy there, and then, patient unfortunately dies over there. This patient says, I'm going to delay therapy. I'm going to start when actually I get the CRAB features, and then I still die there. So do we know if early therapy makes people live longer or better? Do we have any data? Not really. So there's 2 big studies in my mind, 2 big randomized studies. One of them I'm not going to mention, although I haven't mentioned in the slides, but I will discuss it because it's a very important thing to discuss. The study done 8 years ago or so in Europe, and they took high-risk smoldering myeloma patients, and they treated them with lenalidomide and dexamethasone. Half of the patients were treated this way, half of the patients were just observed, right? They got no therapy, and they found that actually, patients had the survival benefit if they got, so they lived longer. The major caveat with this study, that's why I think most people in the US wouldn't agree that this is really informative in this day and age. Problem number 1 is how they define high-risk smoldering myeloma. They use some of the, some specific tests that are, we don't routinely use. And number 2, not everybody got state-of-the-art imaging, and also the new criteria were not included. So the new criteria is a bone marrow plasma cell more than 60%, free light chains ratio more than 100. And nowadays, we almost always do, at least a low dose whole body CT. Many patients have PET scans or MRIs to identify bone lesions. That study just used X-rays. So the theory is that, there's a very, very good chance we probably missed some true myeloma patients in this study. And we know, if you give patients with myeloma Revlimid, they will live longer. So that's why I'm not going into details. The most recent study is a study that was led actually by Dr. Rajkumar here at the Mayo Clinic. It was done through the ECOG cooperative group. and they got patients with high-risk smoldering myeloma based on the Mayo 2020 criteria, and they gave them Revlimid, no dexamethasone. And they, the endpoint of the study, right? What they were looking at basically is, were we able to delay progression to active myeloma and organ damage from active myeloma? Were we able to delay anemia development, hypercalcemia, bone lesions, kidney failure, and just end organ damage? They didn't look at the other stuff, which is, just clinically relevant. And they were able to show that. However, they weren't able to show that there was any survival benefit. So patients didn't live any longer, and there was no quality of life improvement. So patients didn't live any better. Why is that? And again, it's tough to kind of pinpoint specifically why, but one theory is, again, going back to the examples that I showed you, right? Why, if you delay end organ damage, is not my quality of life going to be improved? How does that make sense? And again, having a patient who's been closely followed, because both of these groups were closely followed, irrespective of whether they got therapy or no. If you have somebody closely followed who develops, one asymptomatic bone lesion that causes them no problem, that's still end organ damage based on this study, but the patient feels nothing. So, or you have a slight elevation, your, creatinine, for instance, which means that your kidney function declined a little bit, and then you get therapy and that goes back to normal and the patient feels okay. That doesn't really mean anything to the patient, is the bottom line. And same thing for survival. Maybe patients that were treated later with Revlimid, right? They just waited and got no therapy. They just caught up. And that's, in the end, everybody lived the same length of time. So I guess the other counter argument is, what do I have to lose by starting early? Well, long-term outcomes are not going to be worse. It's not like, oh, you start therapy and you said, doc, oh, the clock is ticking, or maybe I'm starting to develop resistance sooner. No, none of that stuff. There's no issue with, your myeloma outcomes may not be guaranteed to be better, but they're definitely not going to be worse. Cons, of course, there's, drug toxicity. These medications have side effects, financial toxicity. Revlimid can be expensive. And especially, if you're going to get these drugs probably for many, many years. So all these things add up. So there are significant, parameters here to be considered of just saying, I'm going to start therapy early because I have high-risk smoldering myeloma. And again, patient preference is always important, but in these cases where the data is a little bit iffy, I think it's more important. So consider a 90-year-old patient, right, who has high-risk myeloma, and we have this futuristic calculator say you're going to get active myeloma for sure 100% in 2 years. But I'm 90 years old. I don't want to deal with Revlimid. Who knows? I might not have 2 years to live. Fair decision. Or a 40-year-old patient with 3 kids, it's like, I'd rather, do something, keep the tabs on this, and then see how things go. Or somebody who is kind of in the middle, let's say, of age. These are random scenarios. But they already have, kidney dysfunction. They already have osteoporosis or bone dysfunction. And they're like, if I get myeloma on top of this, maybe I'd rather be on something to make this more predictable. Again, fair decision. Or again, 65-year-old patient with bad insurance who's not going to cover their Revlimid. So these are real life scenarios that we consider. So, and we're going to conclude and then we can chat further. So I think many people have given the example, right? Many experts are giving the example like, oh, if you had a high risk, malignant polyp in your colonoscopy, wouldn't you remove it? Or you had a malignant breast lump found in a mammogram, wouldn't you remove it? It should be the same for high-risk smoldering myeloma. Not exactly, because if you remove a malignant breast lump, if you remove a malignant polyp, you're done. You're done. You don't have to worry about them. This is not going to develop into anything. We don't have a therapy yet that we say we're going to start therapy in a high-risk precursor stage, smoldering myeloma, let's say, that's destined to develop into myeloma. If I start that therapy, then I'm going to make a difference for sure in this patient's lifetime. So it's like, it's preparing to go on a road trip, right? And you start a timer, and when you reach your destination, you kind of click back that timer to kind of stop the time. So if starting early therapy in your myeloma journey is just starting the timer when you're still packing your bags, right? Versus starting therapy, versus starting the timer when you're actually in the car. It's not a good idea. Yeah, I mean, it seems that you've kind of prolonged the time, right? Because you started the timer at a different time point, but you're going to reach the destination at the exact same time. But if actually early therapy is going to make you help your car go faster, that's a different story. That definitely makes sense. But to do that, you need well-designed, randomized trials that have length of life, so survival, and quality of life as endpoints. Everything else in between is a little bit iffy. And also we have to consider that, many of these medications, and especially as future myeloma trials are combining more and more medications together, they can cause some side effects. We have to consider that. So, and again, my lame sort of, Star Wars meme here. You have to keep an open mind, follow the data. I think when there's some conflicting data or conflicting consensus or specialist opinions, I think patient preference is the most important. I mean, it's always the most important, but here it's really important. And then randomized trials with survival and quality of life endpoint are the best. But my opinion, sort of take home point, bottom line is I don't think the smoldering myeloma diagnosis is going anywhere anytime soon. That's it.
Awesome. Thank you so much. That was such a great presentation. And I did appreciate your little Star Wars meme at the end. So thank you for sharing that. I think you brought a great point to the pros and cons of starting treatment early. And just to explain it a little better, because I know that there were not a little better, you did a great job, but just a little bit more clear to some patients that are asking, hypothetically, if the smoldering myeloma diagnosis were to phase out, the high risk smoldering myeloma and even maybe some of the standard risk would be absolved into a myeloma diagnosis, and the rest would be considered a precursor condition. So that's why we focus so much on whether or not we should treat this high risk myeloma, smoldering myeloma. I just wanted to clear that up because there were a couple of questions. So thank you. One of the questions that I appreciated, where does neuropathy come to play when it's from the disease and not the treatment? And why is nerve damage not considered organ damage or a myeloma defining event?
Yeah, so that's a great question. So neuropathy is a complicated phenomenon. So problem number one is that, what kind of neuropathy? Yes, and I'm not a neurologist, so I don't want to, misinform people or give, the wrong information, but there are very specific syndromes in which there is a clear causal association between the myeloma protein or the myeloma itself and neuropathy. And these are pretty rare, like amyloidosis, there's IgM-related neuropathy with a specific phenotype, POEM syndrome, cryoglobulinemias, there's some like weird things like that. The reason why we don't consider it a myeloma-defining event is that people can have neuropathy from other autoimmune, etiologies that are very, very common. So the fact that you say you have, and that's assuming, right? That's assuming you have none of the other CRAB criteria. I mean, if you have hypercalcemia, renal failure, there's no question. I mean, you get therapy and that's the end of story, and irrespective of neuropathy. But if you have none of the other CRAB criteria and you have MGUS or smoldering, you have neuropathy that doesn't really fit any of the classic syndromes that I mentioned, which are pretty rare. The reason that you don't treat is because the fact that two things exist together doesn't mean that one is causing the other. So you have some sort of autoimmune neuropathy that's most likely, immune mediated, like CIDP or, idiopathic or whatever. And you have an MGUS, which is also very common. It doesn't mean that one is causing the other. Like it's like having a fire and people are exiting the building. It doesn't mean that people that are there just cause the fire. They're just there because there's something going in this patient's immune system, causing probably both the neuropathy and who knows, maybe contributing to some extent to their MGUS. But you don't consider that causal, and that's a very important thing to define, because it means that many people would get chemotherapy, which is a big thing, right?
Yeah.
So it's very important to sort of secure the causal association.
Not to mention that several, and Velcade in particular, can, worsen neuropathy or even cause it, so you have to.
Yes, and even, honestly, and even in conditions where, like IgM neuropathy or amyloid, where you do treat patients with chemotherapy, although amyloid, I shouldn't mention that. Like, let's say IgM neuropathy, we don't go beyond Rituxan, at least at Mayo, because we really haven't seen any clinical benefit. I mean, these folks, sometimes you give them therapy and you decrease the amount of the monoclonal protein, neuropathy is still there, which tells you that either it's loosely correlated or not correlated, or something else might be going on.
Interesting. Thank you for your thoughts on that. There's several great questions here. Let's target this one. Is there any correlation that you've seen between the type of immunoglobulin and the risk of progression with regards to smoldering myeloma? So IgG.
Yeah, usually, the non-IgGs tend to be considered high risk, at least for MGUS. For smoldering myeloma, not so much, and it wasn't thought to be independent from the other classic, risk factors. So that's what I think. What I'm going to say. I think non-IgG tends to be considered, but it doesn't really matter if you have the other, classically established risk factors, or if you don't have them.
Mm-hmm. It wouldn't be the defining risk factor in progression, at least. Is that what you're saying?
For smoldering, yeah. For MGUS, I think it's still a reasonable risk factor. And all these things, they're just a Google search away if you want to get like more specific numbers and stuff.
Yeah. Be careful though on Google. Who knows what you're gonna
find. Yes. Or you can email me and I can forward,
No, it's okay.
more specifics.
Ida is wondering, did she understand correctly that if you are diagnosed with smoldering, then you definitely had MGUS first? Let's talk about that progression.
Yes, so this is Dr. Landgren has done this study and found that every patient that has had any sort of dysproteinemia, there's always an MGUS phase. There's always a pre-existing MGUS phase. There can be, several years ahead. I think Dr. Hall had presented that data. He mentioned something very lengthy, actually, like at least 20 years before, sometimes maybe longer than that. But I don't quote me on that.
Okay. If you are standard risk smoldering, should you still wait and watch until it progresses?
I mean, I think the consensus, the community consensus is yes. The only setting where we consider some sort of treatment like Revlimid, for instance, is only high risk smoldering.
Yeah. So
if there's any trials, I have to say, always encourage participation in trials for whatever risk they allow and stuff. But so far, I think observation.
Yeah, that's a great point. I appreciate that. Lisa brings up, if you have smoldering myeloma, does that mean that your immune system is already compromised? She's worried about, the risk of walking around with smoldering, being more vulnerable to viruses like COVID and other bacterial infections, that she might do better on a multiple myeloma therapy that can get your M spike down and improve your immune ability to fight germs.
All right, two questions there. So number one, I think, I don't think we have very specific ways of predicting, with a few exceptions, of predicting how immunocompromised the smoldering myeloma patient is. The risk for COVID is slightly higher for smoldering myeloma patients, not for MGUS patients. That was ASH data that was presented last December. But again, even within the smoldering, pool of patients, there's huge variability. I mean, one very crude way is to look at this phenomenon called immunoparesis, where your antibody levels are low, but this is very tricky, and certainly have patients that have very low antibody levels and they get infections. Other patients don't get any infections. And keep in mind, if you're getting frequent infections with smoldering myeloma, that is considered by some to be potentially a reason to actually consider therapy. However, if you're not clinically having any problems from your smoldering myeloma, I should say, starting therapy might not necessarily be a good idea, especially if infections is, periodic, every now and then infections, I guess, is the only thing you're dealing with, because myeloma therapy itself is quite immunosuppressive, at least in the short term. So that's not a very specific answer, but that's also because there's not a very sort of, I think, specific data or consensus to say who is more immunocompromised than the other when it comes to smoldering myeloma.
Yeah, I understand, Lisa, and I understand your concern. I think it's a good question that you bring up, but I was just talking to you about how I talk to hundreds of patients, and I just echo what you were saying, that the treatment becomes immunosuppressive as well. The treatment is hard on your body, and when you're on treatment, you're more susceptible to infections in cases. And so it's not you're on therapy and therefore your M spike is guaranteed to go down and your immune system is guaranteed to go up. I mean, it's just not A plus B equals C in this case. Although I do understand your concern, and it's hard not knowing. I think it's hard not knowing. All right, somebody is wondering if you could summarize again your conclusion about the Mayo study of lenalidomide versus observation. Did you say that there was no PFS or progression-free survival shown in the study?
There was progression-free survival benefit that was shown, but what does that mean, and how important is that for all patients?
Okay.
So it didn't show. So it's, if you give a myeloma medication to a patient with smoldering myeloma, well, I mean, it's right. It's going to delay its progression into active myeloma. It's a bit of a no-brainer. This study, to its credit, was better because it looked at, again, actual end organ damage, just the CRAB criteria, not the secondary neuro criteria and stuff. But it didn't show any length of life presentation. Extension, and it didn't show any improvement in quality of life. So patients didn't live longer or better. That's why I think it comes down to what the patient feels like, doing. I'm not saying that there isn't, but the study didn't show it.
Yeah. Can you?
These are confusing endpoints. Sorry.
It's okay. This is a complicated topic. So it's hard to come up with absolutes like you were saying earlier. David is wondering, can you explain how low hemoglobin level can take you from SMM to MM?
Yeah, so I think this is this just goes to all blood counts, right? When you have more of these clonal plasma cells, I don't want to call them malignant because MGUS and smoldering, I mean, they're malignant, but it's not a malignancy. So the more of these you have, the more they kind of start crowding out the normal cells in your bone marrow. So your bone marrow is not able to keep up, and you see, multiple types of blood counts going down. And we have 3 types, right? Red blood cells, so that's reflected in hemoglobin, white blood cells, platelets. So I think that one of the first to go down is the hemoglobin. That's how I kind of made it to the criteria for diagnosis. And then, there's some clear-cut indications like, oh, your hemoglobin is 7, you have 60%, all right, done. But there's some cases where you have somebody who starts with a normal hemoglobin, let's say, 15, and then next year it's 14, and then the other year it's 13, and then it's 12, and it's still, it hasn't dropped down to like 8 or 9, which is the official criteria, but it's drifting down. So that makes you, wonder, say, all right, this might be actually, an evolving process into myeloma, and we might need to kind of pull the trigger, but it depends, as we discussed.
And I think that shows the importance of seeing a specialist even in the precursor phase, because if you have questions and if you have concerns, those are important, and seeing somebody who specializes in myeloma versus a local oncologist might be able to explain things better or appease those fears that you might be having, and make informed decisions with you. Charles is wondering, given the long timelines for clinical trials and the long follow-ups that are required, when would we be likely to actually have the answer to this question, benefit to early treatment? 20 years from now, 30 years from now?
Yeah, that's a good question. And I think there's another attendee who asked something similar. These are very slow trials, and that's why, that's why we sometimes say, okay, it's reasonable if people are worried or if there's other concerns or that people are very young and they want to consider early therapy, to do it, even if it's, not like by the book, but it's probably going to be several years. I mean, the ongoing ECOG study looking at data, Revlimid versus Revlimid, it's like chugging along. I still might be another like 5, 6, 7 years before it reports anything out.
Mm-hmm.
So I think these estimates are unfortunately quite accurate.
Yeah, it's going to take some time, but that just shows the importance of participating in myeloma research so that we can accelerate it if there's a way to do that. There's another question about, for example, people at MD Anderson and Dana-Farber have started to do standard risk smoldering myeloma trials with immunotherapy such as daratumumab, venetoclax, or even Blenrep to control early and save the heavy duty chemo, like, with the like stem cell transplant for later. What are your thoughts on these kind of trials?
Yeah, so I don't specifically, know the exact design of many of these trials. I think smoldering myeloma it's a rare disease, so it's difficult to get people on trials and it takes forever to complete them. I mean, conceptually, they sound certainly, interesting, but we really can't predict. Something that makes sense in the lab or in our minds might not necessarily translate into benefit for the patient. Number one. And number two, what I'll say is, I think it's really, really important to have, randomization in smoldering myeloma. Of course, if we're talking brand new drugs, right? Like, Blenrep or venetoclax or things like that, you need to have like a phase 2 trial. Phase 2 meaning you don't have a control arm that's not going to get therapy or it's going to get some other form of, therapy like Revlimid. But so if you don't have any experience, you need, to do a small trial with a few patients and see what's up, so you can inform the design. But whenever you can, I think randomized trials, half of the people get one approach, half of the people get the other, are the ones that give us answers.
Awesome, thank you.
So these are all interesting trials. We'll have to wait and see.
Yeah. Larry is wondering if you would recommend, full body PET, CT for MGUS patients instead of a bone marrow biopsy in order to assess the myeloma activity in the body.
Not, I wouldn't consider one or the other. I think, you probably need to have both most of the times. So the bone marrow biopsy gives you different kinds of information. So first of all, I mean, it's needed for the definition. Like you have less than 10%, your MGUS, more than 10% is smoldering. Now, are there cases where, you do a blood test and your M spike is like 0.2 and you're like, okay, what are the chances this is going to be smoldering, right? Very low. So it's okay. We can skip the bone marrow. Certainly, it's done all the time in clinical practice. But I think most people end up getting a bone marrow because that's what shows you the molecular profile of these plasma cells. You can see some of the high risk features, less high risk features. So different sorts of information. The bone scan, be it a PET scan, whole body PET, whole body MRI. I think these kinds of ultra-sensitive approaches are important for smoldering myeloma patients because they can catch very tiny issues. Again, if you have a clear-cut MGUS, M spike of 1, normal light change and stuff, total whole body CT is okay. We still do that though over whole body X-ray. So the new standard is some sort of CT-based or MRI, again, if you have access to it, a based assay. It's more sensitive. And yeah, I would still recommend it even in the lowest of the low risk scenarios. And the reason we try to do it in all patients at some point in time, maybe not right away, but early on after diagnosis, it might save you headaches. Say you have MGUS, and then 10 years later, for some reason, you get a whole body CT and they say, oh, there's an indeterminate lesion there. I don't know what this is. You haven't had a baseline. You're stressing out saying, could this be myeloma? I have to get rescanned or get a biopsy or whatnot. But if you had a baseline, you say, oh, no, this was there 15 years ago, nothing to worry about. So I always do get a baseline. Yeah.
Awesome. Thank you. We have, is there any other questions that you see that you would like to answer before we finish up? There's several, so if any of them catch your eye, I wanted to give you the chance to.
we can, let's see, try and go through some of them. Correlation between degree of indolence and once treatment begins, a slower time to relapse. Yes and no. I think once disease starts, you use different kinds of prognostic, features. So there's some standard or kind of non-high risk patients when they actually get diagnosed with myeloma, but some of these genetic abnormalities might be considered more high risk in the smoldering phase, for instance. So not necessarily. Misto, anything in the horizon that would suggest a new type of treatment for SMM versus first-line treatment. Again, I think as one of the other attendees mentioned, some immunotherapy-based approach with daratumumab are currently being studied. There's, of course, other more kitchen sink light approaches like, combination quadruplet therapy and transplant and stuff. So who knows? Essential thrombocytosis and MGUS, and I think another question, the patient had CML. No, I don't think there's any indication. I think we still use the same prognostic criteria that we use for MGUS and smoldering, and you frequently see various different hematologic abnormalities coexisting in many, not frequently, but not infrequently, especially in referral centers. Recommendations to slow progression of smoldering, I think not any general recommendations. It's, has to be individualized. So gotta know your specific details.
The HealthTree Foundation is studying, just sorry to interrupt, but the question was, are there any recommendations that you can give to slow progression with
to slow progression? Oh, I see. Outside of, treatment approaches, right? Not really. There are tons of laboratory or epidemiologic data, but not really. I guess one thing is keep a healthy weight. There are, I think, pretty decent epidemiologic and basic science data saying that you have more obese folks might have high risk of progression. So that's the only thing that comes close to evidence-based recommendations, but nothing else. And just that's all I can think of.
Is studying with a couple of different doctors the relationship between fitness and myeloma progression, and then diet and myeloma progression. So if those are studies that you viewers are interested in participating in as smoldering multiple myeloma patients for that diet study, and then we'll have more details about the fitness study to come. But as long as you're a part of this chapter, you'll be able to hear about those studies, and when they're ready for people to enroll in, we would love your help so that we can get that answer to the question, is there anything that we could do? We're nearing the top of the hour, so I think we'll end there, but thank you so much for your time answering all the questions. And this was a complicated topic. I think you handled it excellently, and thank you so much for sharing your time with us today.
No, thank you for having me, and thank you for your attention.
Yeah, thank you.
Bye.
We're gonna finish with bye-bye. We're gonna finish for my viewers here with a couple of outro announcements, and then we can end. This chapter meets every other month, so please join us in May as we have a specialist come share their insight on why seeing a multiple myeloma specialist in the precursor stage, whether you're MGUS or smoldering myeloma, is so important. More details to come on that about time, and we'll make sure that you have access to register for it when it's ready. On the 22nd at 6:30 p.m. Eastern is our Florida Myeloma Crowd Community Chapter launch. We're looking forward to that and hope to see you there if you're in the Florida area and would like to join that community. On the 23rd is our Nutrition and Wellness for Myeloma chapter. We're going to be hearing from Dr. Sarah Lee about how inflammation relates to cancer. And then on the 24th at 1 p.m. Eastern is our African American Myeloma Community chapter. We're going to be hearing from financial coach Diana Valentine, how to recognize and overcome financial challenges that African Americans face when seeking treatment for cancer. The link to sign up for any of those events and even more events I have not mentioned today is found at the bottom of this slide and will be sent out in the follow-up email within 48 hours of the event's completion. I will say, if you haven't seen our new website yet, we did a couple of updates. We're always continuing to improve our website, and our team is working really hard. So if you haven't seen our new website yet, make sure to take a look at that today. And as always, I would like to thank our sponsors, without whom this would not be possible: Bristol Myers Squibb, Amgen Oncology, Genentech, Adaptive Biotechnologies, Sanofi, Janssen Oncology, Karyopharm Therapeutics, Takeda Oncology, and AbbVie. Thank you to each of you for taking the time to be with us today. We really appreciate you and hope that you have a great rest of your day. Thanks all.